Good afternoon, everyone. Dr. Campbell, flattery will get you everywhere. Thank you very much. Today I have the distinguished pleasure on speaking on the topic of understanding female reproductive physiology across a lifespan. Can you hear me now? Yes, sorry. Forgive me, I'm a little bit nervous, but bear with me. Can we see this? No. Okay. I would like to start with a confession. I must confess, when familiarizing myself with the depth, scope, detailed but brilliantly efficient nuances and beautiful complexities of female reproductive physiology, I realized that I could not do it justice in one day, 1 week, 1 month, much less 20 minutes. However, in my endeavors, I realized that some lasting impressions were made that left some thoughts. Those thoughts I will share with you, and I suspect you may agree with me as well. Thought 1, we generally underestimate the importance of hormones on the human experience. Thought 2, from the moment of conception to the moment of death, the human phenotype experience is a dynamic interplay of hormonal messages. With that said, let us start at conception and explore the physiological changes associated with the embryological life. It is first important for us to establish genetic sex will determine gonadal sex, which will then determine genital sex. Reproduction, which is the process through which the continuation of your genetic code and existence of the human species from one generation to the next is achieved by fertilization. In an overly simplistic form, when you have an egg that is fertilized by a sperm, you achieve a fetus. If that sperm has an X chromosome, it will form a female genotype. If the sperm has a Y chromosome, it will form a male genotype. At 7 weeks gestation, the gonadal sex is determined based on the presence and the absence of the effects of the activity of the sex-determining region of the Y chromosome. This triggers development of the testes from the bipotential gonads. At 8 weeks gestation, 2 hormones, in particular, testosterone and anti-Müllerian hormone, both of which are derived from the testes, drive male development by promoting the formation of male reproductive structures and suppressing female structures. At 12 weeks gestation, genital sex is determined based on the presence or absence of the effects of testosterone and anti-Müllerian hormone. In the presence of these hormones, genital development progresses towards the pathway of female phenotypes, forming structures such as the labia majora, labia minora, uteral, and vaginal openings. By the end of the first trimester, approximately weeks 12 to 13, the external genitalia begins to show distinct features of male or female characteristics, though they may not be clearly visualized on ultrasound approximately until about weeks 16 to 20. Once the ovary has formed, it directly impacts every facet of a female's life. The formation of the ovary becomes an influential key through which the female experience of life can have physical, intersocial, psychosocial, and even socioeconomic implications. It is imperative for us to note the key building block of the ovary is the oocyte complex, which consists of the oocyte, which is the egg, and surrounding hormonally active cells. By weeks 20, the ovaries will contain approximately 1 million oocytes, These oocytes will play important roles. In particular, one, the source of genetic material for the next generation of human offspring, and two, the oocyte as well as the surrounding cells, in particular highlighting the granulosa cells, as well as the theca cells, are the main sources of ovarian hormone production. The theca cells convert cholesterol to androgens, which when stimulated by luteinizing hormone, and the granulosa cells when produce progesterone and estrogen when stimulated by the follicular-stimulating hormone. These ovarian hormones impact almost every system of the human body, from physical appearance to bone health to cardiovascular health, even the ever-changing emotional state. It is the activation of the ovarian cells that will lead to puberty, sexual maturation, fertility, and eventually menopause, which occurs when these oocyte complexes have been depleted. The oocyte clock, coined by my brilliant colleague, Dr. Campbell, let's talk about it. The number of eggs or oocytes in the human ovary changes significantly over time due to a natural degenerative process called atresia. At 20 weeks, the ovaries achieve a peak amount number of oocytes, approximately 67 million oocytes. However, from that point on, those number of oocytes begin to deplete. At birth, they are reduced to 1 to 2 million. By puberty, reduced to 300 to 500 oocytes. Of these, only 300 to 500 will be ovulated during women's reproductive lifespan, with the rest would undergo atresia. Each menstrual cycle, about 1,000 eggs in each menstrual cycle, about 1,000 eggs begins the maturation process, but typically only one reaches full maturity and is ovulated. The rest undergo atresia. This process continues well until menopause, when the ovarian reserve is nearly depleted. Now that we've highlighted some of the embryological, physiological changes, let's transition to the physiological changes that occur in childhood. It is first important for us to have a general understanding. What happens in the brain affects what happens in the body. However, specifically understanding hormonal interplay throughout the hypothalamic pituitary ovarian axis is key to understanding how the brain exerts its control over ovarian hormone function, reproductive function, and almost every aspect of the body. Female reproductive function commences at the onset of menarche, which is the first menstrual period. And this is triggered by a combination of hormonal and developmental factors. This includes hormonal changes, such as the release of gonadotropin-releasing hormones from the hypothalamus, which stimulates the pituitary gland to release luteinizing hormones, as well as follicular-stimulating hormones. And these hormones signal to the ovaries to produce estrogen, which plays a key role in the development of secondary sexual characteristics and the onset of menstruation. There are also genetic factors that are involved. We have found that families that have a history of early menarche, as well as ethnicities, can play a role in when a female reaches menarche. Nutrition and body fat can also play a factor. It is important and can be important for us to highlight that the excessive low body fat can delay menarche, while healthy amounts of body fat promotes the release of estrogen, triggering the onset of menstruation. Some studies even suggest that girls with higher body mass index may experience menarche earlier. Thank you so much. Take a hint. Right. Environmental changes. Those can also play a factor as well in terms of the onset of menarche. So For example, the exposure of endocrine disrupting chemicals such as pesticides may also impact the timing of menarche. Increased exposure to light and changes in stress can also play a role, and we certainly will get into that a bit more on our next presentation. Certain medical conditions, such as polycystic ovarian syndrome, obesity, and eating disorders can affect the timing of menarche. Physical and emotional stress. High levels of stress during childhood or adolescence can disrupt the hormonal pathways that trigger menarche, potentially delaying and affecting its onset. Let us now take a step-by-step look via the age group of some of the significant changes that occurred in childhood. From birth, the hypothalamus undergoes continuous process of maturation to about ages 6 to 8. At this point, sufficient maturation commences the function of the release of gonadotropin-releasing hormones in a pulsatile fashion, which stimulates the pituitary gland to produce hormones that stimulate the ovaries to produce hormones that, most notably, estrogen and progesterone, which eventually will lead to pubertal changes and menstruation. By ages 8 to 10, another endocrine organ of note, the adrenal gland, undergoes maturation producing androgens such as dihydroepiandrosterone, which is a precursor molecule to sex hormones, including testosterone and estrogen. This leads to the onset of pubarchy, which is associated with the appearance of changes such as pubic hair, axillary hair, body odor. By ages 8 to 13, breast development. The rise in follicular-stimulating hormone and luteinizing hormones stimulate the ovaries to produce estrogen. Breast budding is usually the first outward sign of puberty. This stage occurs earlier in some populations due to genetic and environmental conditions. By ages 9 to 14, females will typically experience growth spurts in response to increased stimulation of estrogen and growth hormones, which stimulate rapid growth. Peak height velocity occurs about 1 to 2 years before menarche, also explaining why, comparatively, girls often have a growth spurt earlier than boys. By ages 10 to 16, females will experience menarche. This is the first menstrual period, which usually occurs about 2 years after telarche. It indicates that the ovaries are mature enough for cyclical hormone production, but does not always mean ovulation is regular yet. Early cycles are often without ovulation for the first 1 to 2 years. And finally, by ages 12 to 18, the cyclical interplay of hormones throughout the hypothalamo-pituitary axis becomes increasingly efficient, where the hypothalamus stimulates hormonal production of the pituitary gland, which then stimulates production of the ovarian hormone, which themselves act as a feedback loop, impacting the production of hormones, impacting the hypothalamus, impacting its production of hormones in a very fine-tuned effect, and it actually becomes more consistent and regular, completing the transition into adulthood, facilitating the monthly release of a mature egg for fertilization. Now that we have arrived to adulthood, for the purposes of this presentation and the interest in time, I would like to focus our attention to some of the physiological changes specifically in relation to pregnancy. What is the difference in pregnancy versus the non-pregnant state? All right. It is the placental unit. It takes full control, almost hijacking the maternal endocrine hormonal system, creating an internal physiological environment advantageous to the growth and development of the fetus. During pregnancy, The key function of the placenta, is that of an endocrine organ with wide-spreading effects of both steroid and protein hormone production. For example, it stimulates estrogen, which in turn stimulates both uterine growth and breast tissue growth, stimulates progesterone, which in turn prevents premature uterine contractions. It stimulates human chorionic gonadotropin hormone, which is detected in pregnancy tests, and this maintains progesterone production from the corpus luteum. Additional hormones may include placental growth hormone, which promotes placental growth, human placental lactogen, which aids in milk production for nourishment of the neonate, relaxin hormone, which aids in the relaxation of pelvic and intercostal ligaments that accommodate a growing fetus. What are some of the other changes that occur throughout pregnancy? Most notably, in the first trimester, you have an increase of the human chorionic gonadotropin hormone, which is associated with symptoms of nausea and vomiting, which you may experience in the first trimester. It is also important for the hypodynamic circulation that occurs. In the second trimester, the increase in progesterone, which accounts for vasodilation effects, which explains for the decrease in the blood pressure which one may experience during pregnancy. Orthostatic hypotension, which one may experience, water retention, as well as the increase in blood volume. The human placental lactogen releasing hormone is also associated with insulin resistance, predisposing patients to gestational diabetes. Now that we have explored reproductive years and highlighted some of the changes associated with pregnancy, let us now finally take a quick look at menopause and some of the main associated physiological changes. What is menopause? It's the cessation of menstruations for a period of 12 months or more, and it's not attributable to any other obvious causes. As we return back to hypothalamic pituitary axis, we can see, due to the gradual depletion of oocytes over time, the ovary's ability to produce its various hormones, namely estrogen and progesterone, begin to decline, while the feedback loop to the hypothalamus and the pituitary stimulates increased production of their hormones, namely follicular-stimulating hormone and luteinizing hormones, to counteract the ovarian hormonal functional decline. All right, now to the part where I suspect a lot of us here can understand or relate to and be sympathetic with. Almost every system of the body is affected by these hormonal changes. In menopause, reproductive system is affected. You can have irregular periods, which can then lead to complete cessation. Some women may experience hot flashes, feeling of intense heat, often sweating and flushed face, night sweats that occur during night, leading to sleep disruption, vaginal dryness, which usually caused by the decrease in estrogen that causes a thinning of the vaginal lining, causing dryness and discomfort during intercourse, loss in libido. The endocrine system can also be impacted by these hormonal imbalances. Fluctuations in your estrogen and progesterone levels can cause a wide range of symptoms, including mood swings, irritability, and fatigue. The thyroid system itself can also be affected, where persons may experience symptoms such as weight changes, fatigue, hair loss. Your heart health can be affected by this. Increased risk of heart disease, where there's an increased risk of heart disease. Decrease in estrogen levels can contribute to the change in cholesterol levels, increasing your risk of heart disease. Some women may experience palpitations, report feeling heart racing, skipping of the beats, and often associated with hormonal fluctuations. High blood pressure can also be associated, where there can be a rise due to menopause, due to changes in the vascular system, as well as the vasodilatory effect of progesterone. One's musculoskeletal system can be affected. Of note, osteoporosis, where the reduction in estrogen, which normally has a protective effect on the bones, decreases, making the bones weaker and persons more susceptible to fractures. One may also experience joint pains as estrogen levels drop, affecting mobility. Your nervous system, which we'll get into a bit more in our next presentation, where one can experience mood swings, memory loss. Someone will complain of brain fog, inability to remember things, just sleep disturbances, hair thinning, nails could become brittle, your gastrointestinal system. One could experience constipation, diarrhea, bloating, urinary system because of the thinning of the urinary tract. One may get predisposed to urinary tract infections, as well as there's a weakening of the pelvic floor muscles that could predispose patients to increased frequency, as well as urination and leaks. Psychological and emotional well-being, symptoms of depression and anxiety can occur because of these changes affecting serotonin levels, contributing to feelings of sadness and anxiety. And we will certainly get into that a bit more. The severity and duration of these symptoms vary from women to women. Some experience more mild symptoms, while others may face more significant challenges. Sometimes, generally, subside over time, but for some women, they can last for years. It is important for us to note that the female may experience these signs and symptoms for years prior to menopause, as well as for years afterwards. This combined duration of time is known as the climacteric period. So in summary, as we reflect on our initial thoughts on the physiological changes throughout the lifespan of the female, one, we can conclude that the human experience is significantly affected by the changes of hormone throughout a female's lifespan. And two, they can have significant psychological as well as physical effects. And three, in turn, this may have both psychosocial and socioeconomic effects. Now, we will turn over to my esteemed colleague that will speak in detail about the psychological effects of hormone changes. Thank you so much.